What's good, YouTube? I'm Jay, and I'm back again with another video. If you're a respiratory therapist seeking to pass the TMC exam, then you come to the right place. Listen, I produced 2 videos, on our way to about 30 or 40 videos concerning content for the TMC exam. Now, if you look behind me, you will see tonight we want to talk about arterial blood gases. Now, I'm not here to teach you respiratory therapy. I'm here to help you to pass the TMC exam on your first or your very next attempt. And if you're ready to go, let's do this. Okay, guys, tonight is arterial blood gases for the TMC exam. Now, I have the entire board covered, so we're going to do this in an order. I'm going to start from my left and work to my right. And you'll see at the very top of the board, there's Roman number 1. And then in the middle, there's Roman number 2. And then all the way to the right, there's Roman number 3. And we'll work from left to right all the way down the board. Okay? Tonight, we're talking about arterial blood gases, as I mentioned, and what you need to know for the TMC exam. Now, we're starting out number 1 with respiratory acidosis. What are the causes of respiratory acidosis? Increased CO2, increased dead space, or hypoventilation. I've also showed you the correction. To correct respiratory acidosis, you have to increase the respiratory rate or increase the tidal volume or decrease dead space. On number 2, we have respiratory alkalosis. What are the causes of respiratory alkalosis? Well, a decrease in the PCO2, anxiety, pain, and hypoxemia. And in the middle of this board, somehow failed to do it on number 1, but I'm showing you an example of respiratory alkalosis. A pH of 7.52, a PCO2 of 25, and a bicarb of 25. This would represent respiratory alkalosis. How do you correct respiratory alkalosis? Well, you decrease the respiratory rate, give meds for pain, or treat the anxiety. Usually you'll see the anxiety in asthma patients because they can't breathe, okay? And number 3 is metabolic acidosis. What are the causes of metabolic acidosis? Well, a decrease in bicarb, diarrhea, aspirin toxicity, diabetes, renal failure, starvation, DKA or diabetic ketoacidosis. This blood gas in the center of this screen would represent a metabolic acidosis, a pH of 7.10, a PCO2 of 20, and a bicarb of 10. Can't you see how that's metabolic acidosis? To correct metabolic acidosis, you have to correct the patient issue. Whatever those, if you look on the left, they have a lot of issues. You have to correct the patient issue, correct the renal failure, and then you have to treat the diarrhea. Number 4 is metabolic alkalosis. The causes of metabolic alkalosis, or some of the causes of metabolic alkalosis, is an increase in bicarb, NG suction, vomiting, injection of sodium bicarb in the blood. A blood gas that would represent metabolic alkalosis would look like this: a pH of 7.56, a PCO2 of 42, and a bicarb of 34. How do you correct metabolic alkalosis? Well, you have to stop the vomiting, and DC the NG suctioning, and stop the bicarb ingestion. Now, Roman number 2, I put this in here so that you can be reminded that you must know this, because I'm assuming you already know how to interpret blood gases. What I'm sharing with you is things that you will, without a doubt, see on a TMC exam. So you see the little line with the graph that I made, 7.40 in the middle that represent a normal pH, and to the left 7.35, which is acidotic, and 7.45, which is alkalotic. A normal blood gas pH is 7.35 to 7.45. A normal PCO2 is 35 to 45. And a normal bicarb is 22 to 26. If there is something wrong with the PCO2, that represents a respiratory problem. If there's something wrong with the bicarb, that represents a metabolic problem. Again, I'm not trying to teach you acid-base balance. I'm trying to teach you how to take the TMC exam and pass. There's another scenario on the exam that you should be aware of. And if you look at number 5, it says respiratory metabolic acidosis. And the blood gas of a respiratory and metabolic acidosis will look like this: a pH of 7.22, a PCO2 of 59, and a bicarb of 16. Can't you see that? Neither the PCO2 nor the bicarb are helping the pH back to normal range. So this represents a respiratory and a metabolic problem, acidosis. And number 6, we have an example of a respiratory and metabolic alkalosis. The pH is 7.47, the PCO2 is 29, and the bicarb is 22, which represent a respiratory and a metabolic alkalosis. Now, I've asked you not to take notes during these videos because I'm not standing in front of the board. I would rather you screenshot the board and maybe copy out or just listen to it briefly. These are very short and sweet videos that I'm putting out, but there's a ton of information on this board that you will see on the TMC exam. And my purpose is that you pass the TMC exam on your very next attempt. Roman number 3, all the way to the right. And I added these in here because sometimes when you miss the exam by 1 or 2 or 3 points, it's because you have did so much studying in patient assessment and hemodynamic and mechanical ventilation until you forget these little things. And I want to make sure that you keep these in a place where you know that you know this information. Okay? These are some must-knows that you must know. You might not study them every day, but you must know them for the TMC exam. The first one is that the first step before drawing an ABG is what? Check the chart and confirm the order. You don't know how many times that this question is missed on the exam. The first thing you do before drawing ABG is to check the chart and confirm. An adequate amount of blood for a blood gas is 2 to 4 cc's. And you do know that we use a heparin in the syringe when we stick ABG. In today's world, heparin comes in the syringe. An arterial puncture hazard. Number 1 is bleeding. Number 2 is obstruction. Number 3 is infection. How long can you wait before running an ABG sample? 15 minutes. 15 minutes, and we know that we have to put it on an ice slush. When we draw it, we're not going to run the blood gas right away. Make sure you put it in an ice slush, but no longer than 15 minutes, you have to run that blood gas. Other way to assess collateral circulation, other than the Allen test, you can use a Doppler ultrasound, or you can use pulse oximetry. When or what is fully compensated when it comes to arterial blood gases? Well, the pH is normal. And in order for it to be fully compensated, the PCO2 and the bicarb must be moving in the same direction. At what pH will we intubate a patient? 7.20. A sudden decrease in the end-tidal CO2 of a mechanical ventilation patient is caused by what? Massive pulmonary embolism, or the patient could be disconnected from the ventilator. The most common site for transcutaneous electrons are where? The chest, the abdomen, and the lower back. Go ahead and screenshot this board for me, because all of the information on this board you will see on the TMC exam. That's why I call it respiratory therapy essential for the TMC exam. All of our content is not about teaching you how to become a respiratory therapist. It's about how and what to look for on the exam. Okay, guys, I'm back. There it is. Now, there is a ton of information about arterial blood gases that you should know about for the TMC exam. However, what you see on my board is things that we know that you must know for the TMC exam, and could be just a reminder for some of you. But I can assure you, if you master the information on this board, you won't have any problem with arterial blood gases on the TMC exam. Now, we'll talk more about blood gases when we get to mechanical ventilation, when it comes to initiation of mechanical ventilation and monitoring the patient while they're on the ventilator. However, this is totally different what we're giving you for today. But remember the thing that you have, because you will see them again. Hey, hit that like button, subscribe to my channel, turn on a notification bell, because I'm going to be giving you a video every week in order that you may pass the TMC exam on your very next attempt. And until next time,